In this mini tutorial, we're going to think about the autonomic innervation of the iris and the eyelid. And the reason we're focusing on these two structures is because they are clinically very, very important and form an integral part of assessment of cranial nerves. So let's start off by diagrammatically drawing the eye. So this is how I'm going to draw the eye. There's the eyeball itself, the surface of it covered by the cornea. Here is the pupil, which we're going to shade in black. Now, the colour scheme which I'm going to use is as follows. I'm going to use black lines, typically to refer to sensory or motor axons. I'm going to use red lines to represent sympathetics. And I'm going to use blue lines to represent parasympathetics. In addition, I'm going to use red and blue to represent structures innervated by sympathetics and parasympathetics, respectively. So if we think about the pupil and the surrounding iris, the muscles of the iris which are supplied by the parasympathetics are known as the sphincter pupillae muscles, and they're arranged in a concentric orientation like this. So sphincter pupillae is arranged concentrically around the pupil, and when it contracts it makes the pupil smaller. So parasympathetic stimulation causes smaller pupils. The sympathetic innervation to the iris leads to pupillary dilatation, and this is because the sympathetics supply the dilator pupillae muscles, which are arranged radially around the pupil. And as you can see from the orientation of dilator pupillae, when they contract, they stretch the iris and pull it open, making the pupil bigger. Regarding the eyelid, I'm going to focus on the important muscle which opens the eyelid, and that is levator palpebrae superioris, which we're going to shorten to LPS. And I'm just going to represent LPS like this here, levator palpebrae superioris, which is predominantly innervated by somatic motor fibres, but there is also a sympathetic component to the innervation of LPS, which will come in later on in the mini tutorial. So now that we've defined the structures which we're interested in terms of their innervation, let's think about where that innervation starts. And we're going to draw the brainstem here. So here is the midbrain, pons, medulla, and then the spinal cord down at that level. And the two nerves which are important for this mini tutorial are the trigeminal nerve, so that's nerve 5, the trigeminal nerve, and the oculomotor nerve, i.e. the third nerve. So the two cranial nerves which you're going to be focusing on are 3 and 5. And in the case of the innervation to the pupil, there is a lot of hitchhiking going on. And if you're not sure about what cranial nerve hitchhiking is, I strongly recommend that you watch the mini tutorial specifically on that topic. Now, the first nerve which I'm going to draw on is the trigeminal nerve, and I'm going to consider the somatic sensory component of the trigeminal nerve, that being the part of the trigeminal nerve which is sensory to the cornea. So this would be a branch of the ophthalmic division of the trigeminal nerve, and it is sensory to the cornea. So let's draw that going all the way back into the brainstem and synapsing in the brainstem. So the branch of the trigeminal nerve which is sensory to the cornea is 5A, the ophthalmic division. Now, the ophthalmic division of the trigeminal nerve has two important branches for the purposes of this mini tutorial. The branch found roughly in this region, near the orbit, is the short ciliary nerve, the short ciliary branch of the trigeminal nerve. And the more proximal branch is known as the nasociliary nerve. So these are the two important branches of 5A for the purposes of our mini tutorial. This region here is the orbit, where the eyeball is found. This region here is roughly at the level of the superior orbital fissure, and this region here is at the level of the cavernous sinus. And actually I'm going to draw the cavernous sinus on right now at this point, and we'll draw the cavernous sinus on in purple. So this box which I'm drawing here is the cavernous sinus. So this is the cavernous sinus. And as you should recall, the cavernous sinus is important for the hitchhiking of sympathetics onto cranial nerves. An additional feature which we need to include is the ciliary ganglion found within the orbit. So here is the ciliary ganglion, which we've covered the basics of in a previous tutorial. So now that we've got the basic framework, let's add on some detail. And the first thing we're going to think about is the sympathetic innervation. Now, the sympathetic innervation to the pupil, as you should know, arises from the walls of blood vessels supplying the head, and the sympathetic preganglionics supplying the head can be found from approximately the T1 spinal cord level. So sympathetic preganglionics from the T1 spinal cord level ascend in the sympathetic chain up to the top, to the superior cervical ganglion, where they synapse with postganglionics. Those postganglionics then leave the superior cervical ganglion and run along the surface of the carotid arterial system. So here we're going to draw on the internal carotid artery. So this is the internal carotid artery, and running along the surface of the internal carotid artery are sympathetic postganglionics, which have come from the T1 spinal cord level. Within the cavernous sinus, these sympathetics leave the internal carotid artery and hitchhike along the ophthalmic division of the trigeminal nerve through the ciliary ganglion into the orbit, and then they enter the eyeball and supply dilator pupillae. So we can see that the sympathetics are following our principles of cranial nerve hitchhiking, where they left the vessel within the cavernous sinus, hooked up with 5A, passed through the ciliary ganglion without synapsing, entered the eyeball to supply dilator pupillae. But that's not the entire story with regard to the sympathetic supply to the eyeball and the eyelid, because there is a second component. And to appreciate that second component, we need to draw on some parts of the oculomotor nerve. Now, the oculomotor nerve has a motor component, as we've talked about in the past, and that motor component is found within the midbrain, in an area of the midbrain called the oculomotor nucleus. So the oculomotor nucleus is found in the midbrain, and it contains motor neurons whose job is to supply the extraocular muscles, and one of those extraocular muscles which the oculomotor nerve supplies is levator palpebrae superioris. Okay, but remember, it also supplies other extraocular muscles as well. So the motor component of the oculomotor nerve arises from the oculomotor nucleus, travels through the cavernous sinus, enters the orbit, and supplies LPS and some other of the extraocular muscles. In addition, we have a second component to the oculomotor nerve, which is also found within the midbrain. And this nucleus is known as the Edinger-Westphal nucleus. So let's just write that out. So the second component of the oculomotor nerve arises from the Edinger-Westphal nucleus. And the Edinger-Westphal nucleus provides parasympathetic preganglionics to the oculomotor nerve. So let's draw on those parasympathetic preganglionics for at least part of their course. They start off in the midbrain, pass with the oculomotor nerve through the cavernous sinus, and then in the orbit they leave the oculomotor nerve and enter the ciliary ganglion. Now we're going to complete the parasympathetics in a little while after we've finished off the sympathetic innervation, because there is a second branch of the sympathetics which leaves the internal carotid artery in the cavernous sinus, but that joins up with the oculomotor nerve, and it runs with the oculomotor nerve until it gets to levator palpebris superioris, where it supplies a relatively small population of smooth muscle fibres which have the same function as levator palpebris superioris, i.e. they raise the upper lid and keep the eye open. So levator palpebris superioris has actually got a dual innervation essentially. It's got motor innervation coming from the oculomotor nucleus, and it's additionally has sympathetic innervation coming from the sympathetic chain. And we're going to talk about the clinical importance of this a little later on. But for the time being, let's return to the parasympathetics. And we'd gotten to the ciliary ganglion in the orbit, where the parasympathetic preganglionics, which had arisen from the Edinger-Westphal nucleus in the midbrain, had entered the ciliary ganglion in the orbit. At that point, they synapse on parasympathetic postganglionic neurons in the ciliary ganglion, which send their axons to sphincter pupillae, which cause pupillary constriction. So you can see here how the sympathetic and the parasympathetic systems are able to have antagonistic actions. The sympathetics innervate the radial fibres which make up dilator pupillae, causing the pupil to expand. The parasympathetics innervate the circular fibres of sphincter pupillae, causing the pupil to contract. So now that we've looked at the innervation to the pupil and the upper lid, we're in a position to think about some clinical scenarios. So what we're going to do is we're going to put some lesions in various places. So the first lesion I'm going to simulate is an interruption to the sympathetic supply to the head and neck. And this could be caused by a number of things. A classic cause of this is an apical lung tumour, which can erode into the upper parts of the sympathetic chain, thus destroying sympathetic nerves. And the name of the syndrome that this typically would lead to is known as Horner's syndrome. So Horner's syndrome is a particular syndrome referring to a loss of sympathetic innervation to part of the head. So let's have a think about what the implications of disruption to the sympathetics could be. So we would have lost sympathetic supply, which runs along the internal carotid artery and supplies two major structures. We would lose supply to the dilator pupillae muscles, and additionally we would lose supply to the smooth muscle component of levator palpebris superioris. So let's think about the two effects that would have. The first effect would be that because we've lost supply to dilator pupillae, there would be unopposed parasympathetic activity, leading to a small pupil. So the first effect we would see in Horner's is a decrease in pupil size. The pupil would get smaller due to unopposed parasympathetic activity. The second effect is related to the loss of sympathetic supply to levator palpebris superioris, which would result in decreased tone in LPS, meaning that it would not be able to keep the upper lid open. So the upper lid would partially close. And the name for this is known as ptosis. So in Horner syndrome, we see a small pupil and we see ptosis, the upper lid drooping down. Now, there is actually a third feature which we see in Horner syndrome, which I've not included on the diagram, but which I could very quickly add. And that's related to the fact that, of course, the sympathetics to the head don't only supply the eyes, they also supply the skin. And you should be aware that sympathetics supplying the skin lead to sweating. So if we have lost sympathetic innervation to the skin, we would lose sweating to a given area of the face, and that would lead to the condition known as anhidrosis, i.e. loss of sweating. So that's Horner syndrome, leading to the classic presentation of ptosis, meiosis, and anhidrosis. So now let's consider a lesion somewhere else. So this second lesion I'm going to put here, at the point where the oculomotor nerve emerges from the brainstem. So this might be caused by compression by a tumour, for example. So if you look where I've put the lesion, it has actually affected both components of the oculomotor nerve. And this is going to have important implications both for the extraocular muscles and for the pupil itself. Let's consider the pupil first. So in a third nerve palsy, where we've affected all of the components of the oculomotor nerve, one thing that we're going to lose is innervation to sphincter pupillae. And if we have lost innervation to sphincter pupillae, that means we're going to have unopposed sympathetic activation, meaning that the pupil is going to be big because we've lost the muscle which makes the pupil small. So in a third nerve palsy, we have lost the innervation to sphincter pupillae, leading to a big pupil. The second component which we've lost is the somatic motor innervation to levator palpebrae superioris. And regardless of whether the innervation is somatic or sympathetic, the action is the same. So in the case of a third nerve palsy, we are also going to get ptosis. The upper lid is going to droop because there is not going to be adequate tone in levator palpebrae superioris. So an oculomotor nerve lesion, a complete oculomotor nerve lesion, has got a big pupil and a droopy eyelid due to loss of innervation to levator palpebrae superioris. In addition to that, we have also lost the innervation to other extraocular muscles as well. Now, it's beyond the remit of this tutorial to go through the details of the extraocular muscles, but you should watch my other video on eye movements to get clarification on what the effect of that would be. But a complete third nerve palsy has three main effects. Now, there is a second type of third nerve lesion, which is actually quite interesting. And in order to appreciate that, I just want to draw a transverse section through the oculomotor nerve. So this is a transverse section through the oculomotor nerve. Running within the oculomotor nerve are, of course, small vessels, which are supplying oxygen and nutrients to the axons within the oculomotor nerve itself. And interestingly, the motor fibres and the parasympathetic fibres run in different places. The motor fibres tend to run deep in the nerve, like this, and the parasympathetic fibres tend to run superficially. And what can happen is, say for example in diabetes, where you can get microvascular disease. In diabetes, that central vessel that we see here can become blocked by diabetic vasculopathy, and that blockage can lead to death of the central motor fibres within the oculomotor nerve. However, the more peripheral fibres remain intact because they take their blood supply from vessels running along the surface of the oculomotor nerve. And in this case, we can get a kind of dissociation. So in this case, what we can see is a displaced pupil due to loss of innervation to extraocular muscles, but the actual pupillary size is normal because the parasympathetic fibres have been spared. So that's quite an interesting example of another type of third nerve palsy, which could be caused by diabetes, say. So I hope that this has proved useful to you, and I'm going to be producing another couple of mini tutorials on other clinically important autonomic cranial nerves. Okay, thank you.